Hi and welcome back to another video of Medic Notes. This video is on approach to upper GI bleeding. Upper gastrointestinal tract bleeding is defined as bleeding that occurs proximal to the ligament of Treitz. The ligament of Treitz is the suspensory muscle of the duodenum that connects the DJ flexure to the connective tissue surrounding the celiac axis and superior mesenteric artery. Patients commonly present with hematemesis, which means vomiting of red blood or coffee ground vomitus, or melena. Patients can present with hemorrhagic shock, hence initial assessment begins with the assessment of the hemodynamic status of the patient. There is a spectrum of presentation which corresponds to the rate of bleeding. Patients who present with hematemesis of bright red blood have a faster rate of bleeding as compared to a patient with coffee ground vomitus. Similarly, patients who present with passage of dark red blood have a faster rate of bleeding as compared to a patient with melena. The passage of dark red blood may indicate a massive UGIB which is masquerading as PR bleed. Factors that are predictive for UGIB includes patient-reported history of melena, melanic stool on examination, blood or coffee grounds detected during ing lavage and ratio of bun to serum creatinine more than 30. For history and examination, ask the nature of bleeding. Is it hemoptysis or hematemesis? Hemoptysis means bloody expectoration from the larynx, trachea, bronchi and the lungs. Patient will describe a sensation in their throat followed with the abrupt expectoration of blood. Whereas hematemesis, vomited blood might be mixed with food particles. Fresh red blood suggests moderate to severe bleeding. Coffee grounds vomitus as altered blood due to gastric acid suggests limited bleeding. Other bleeding include melena and frank per rectal bleed. Melena is the passage of altered blood, black tarry stool, that originate proximal to the ligament of Treitz. There are fresh melena and stale melena. Whereas frank PR bleeding. Very brisk upper GI bleed which can present as frank PR bleeding as blood passes down so fast it doesn't get altered. In the presence of hemodynamic instability, this indicates severe bleeding. Next, determine whether it is a variceal or non-variceal bleed. For variceal bleeding, ask if there is any previous variceal bleed, ask patient if they go for regular banding or OGD screening and banding. Any history of chronic liver disease, ask for risk factors like alcohol ingestion, hepatitis B or C, any regular follow-up for liver disease. Non-variceal bleeding can be due to many causes. Peptic ulcer disease is the most common cause. Ask for history of dyspepsia, previous H. pylori infections, previous endoscopy performed. Drug history like NSAIDs, antiplatelets, steroids, anticoagulants. Secondary to cirrhosis-induced hypergastrinemia from decreased hepatic metabolism of GI hormones. Another cause is stress ulcer, such as curling ulcer and Cushing's ulcer. Mallory-Weiss tear, where its diagnosis requires a high index of suspicion. It is characterized by arterial bleeding, secondary to violent retching following alcoholic binge. This leads to one or more longitudinal fissures in the mucosa of the herniated stomach at the gastroesophageal junction. Majority of bleed with stop spontaneously with non-operative management, by decompressing stomach and give antiemetics. Dieulafoy's disease, which is arteriovenous malformation of the gastric fundus. It presents with massive or recurrent bleeding coming from an area of apparently normal gastric mucosa. Characterized by a large tortuous arteriole in the submucosal that bleeds. More common in males, with multiple comorbid. Suspect in patients presenting with UGIB with no history of alcohol abuse or NSAIDs use. Malignancy like gastric or esophageal carcinoma can also cause bleeding. Early lesions might be asymptomatic, or present with epigastric pain and dyspepsia. Intermediate lesions may cause anemia, melena, hematemesis, early satiety, dysphagia, nausea or vomiting, and bloatedness. Late lesions cause loss of appetite, loss of weight, palpable epigastric mass, obstructive jaundice. Rare cause includes gastric antral vascular ectasia, which are dilated mucosal blood vessels that often contain thrombi in the lamina propria. More common in elderly women with chronic occult GI blood loss, associated with autoimmune connective tissue disorder and chronic liver disease. Next, quantify the amount of bleeding. If the patient presents with hematemesis, ask how much blood vomited. When patients have hematemesis, there can be up to 1.5 liter of blood in the stomach. Is patient symptomatic? Any symptoms of chest pain or shortness of breath? Gauge percentage of blood loss, whether it is class 2, 3, or 4. Ask about other significant medical history. Of importance is cardiac history, renal history. Presence of heart conditions or ESRF will predispose patients to fluid overload during resuscitation. Ask about other significant medication history such as antiplatelets or anticoagulants. Antihypertensive medications should be stopped in acute bleed. Beta blockers can mask tachycardic response. Also ask if patient previously on any proton pump inhibitors or H2 antagonist. Examine the patient. Check vital signs, digital rectal exam to confirm melenic stool, determine etiology whether as varicose or non-varicose, look for complications like signs of anemia, check urine output, any peritonism. These are the differential diagnosis of upper GI bleeding. Can be from esophagus, gastric, duodenum, or other causes. For management, fluid resuscitation, ABC, request blood transfusions, ECG, and give crystalloids for resus. Other adjuncts include ING-tube, ART-line, CBD, intubation if indicated. Early medications are IV omeprazole 80 mg bolus followed by 8 mg per hour for 3 days. It decreases stomach pH which helps in stabilizing clot formation. If suspecting varices, give IV somatostatin 250 mcg followed by 250 mcg per hour and antibiotics. If planning for urgent endoscopy, KIV for IV erythromycin. Withhold all antiplatelets, anticoagulants, NSAIDs, and antihypertensive. Urgent OGDS may be indicated for patients with hemodynamic instability despite fluid resuscitation. Active bleeding, or suspected variceal bleed. OGDS is a diagnostic and therapeutic modality. It is diagnostic to confirms UGIB and identify source of bleeding. Biopsy of gastric mucosa with CLO test can be done if there is ulcer. All gastric ulcers should be biopsied with 6 bites. It can also be therapeutic with injectables like adrenaline, sclerotherapy, and procoagulants. Thermal like heat diathermy, or argon plasma coagulation, and mechanical like hemoclips, and endoscopic variceal ligation. Varices bleeding can be stopped by band ligation or sclerotherapy. Non-variceal causes are stopped by hemoclip, injection of adrenaline, or APC. Dual modality better than single as less risk of recurrent bleed and mortality. This is the Forest classification of UGIB to predict risk of rebleeding. 1A is spurting arterial bleed, 1B is oozing venous bleed. 2A is visible vessel, 2B is adherent clot, 2C is hemodin-covered base. Type 3 is clean base lesion with no bleeding. For subsequent management, 80 mg bolus IV PPI followed by continuous infusion of 8 mg per hour of IV PPI for 72 hours, then convert to oral PPI. For duodenal ulcer bleeding, presume this is related to H. pylori infection. Treatment involves triple therapy with omeprazole, amoxicillin, and clarithromycin 500 mg BD, followed by urea breath test at clinics. Scoring systems are available to guide clinicians on the risk of rebleeding. This includes the Rockall and Glasgow Blatchford bleeding score. That's all for this video. Thank you.